Hello everyone, I am Dr.Usman Mumtaz, PGR LGH Unit 2. Today the topic of my discussion is ptosis examination. Every examination has different components. Let us start with inspection. The examination for ptosis has following things to be looked upon, which include number 1, lid crease. Then comes the signs of paralysis, any previous scar mark, swelling, pigmentation and globe size. All these have significance as lid crease is essential to identify the congenital ptosis. Signs of paralysis are important to see if there are other nerves involved in this condition, and scar marks show the previous surgeries. The swelling gives the impression of pseudotosis, so does the globe size. Then comes the papillary reflexes. The most important among them is Hershberg's reflex, for which the light is held at arm's distance away from the patient and is used as a target, and then the reflexes onto the cornea of the patient are seen. If they are central, it is orthophoria, and if it is deviated to the papillary margin or between the iris or to the iris margin, then this shows there is deviation according to the measurement of the angle. Then comes the direct light reflex, indirect light reflex and swinging light reflex. These reflexes are important to see if the Hershberg test is giving the true positive value or it is false positive value, as if the pupil is dilated, this may show that this may cause misinterpretation of false negative result. This is also important to see if there are other causes of the ptosis like Horner syndrome and all that. Then comes the accommodation. Extraocular movement in this case is important, and it includes duction, version, vergences and saccades. The saccades, when the saccades are performed in vertical position, the finger or the target that is in the upper position is held at that position for a longer time to see if there is fatigability or there is no fatigability, which is important for myasthenia gravis and also for the Cogan's twitch. Now there are different measurements which are important in the cases of ptosis. First is MRD, that is marginal reflex distance. It is the distance of reflex of torch that is held at arm's length from the patient and to the upper lid margin. This is normally 5 millimeter, and if it is less, that can be the cause of that can show that there is ptosis. Then comes the palpebral fissure height. It is the distance between the upper and lower lid margin. Normally it is 7 to 10 in male and 8 to 12 in female. If it is less, this shows that there is ptosis. Now the ptosis is then graded as, if it is 2 millimeter, it's mild ptosis. If it is 3 millimeter, it is moderate, and if it is 4 or more than 4, it is severe ptosis. Then comes the levator function. For levator function, the patient is asked to look downward, and then the function of frontalis is obscured by pressing against the upper eyelid, eyebrow, and then the patient is asked to look in the upward direction as far as possible, and then the function of the levator is assessed. If it is less than 4 millimeter, it is poor levator function. If it is 6 to 12 millimeter, it is fair, and if it is 12 to 14, it is good, and if it is 15 or more, it is normal function. Upper lid crease is the distance between the lid crease and the upper lid margin. It is normally 8 millimeter in female and 7 millimeter in male. Then comes the Bell phenomena. Bell phenomena is important to estimate if there is overcorrection in ptosis. This will not lead to exposure keratitis. So we ask the patient to close his eyes forcefully while keeping the upper eyelids open forcefully. The eye rolls upward and outward. This shows the Bell's phenomena. Then is the jaw winking phenomena. Jaw winking phenomena is important to see the apparent connection between the third nerve, between the third nerve and the trigeminal nerve. That's all. Thank you very much.